HIV 0.3%, hepatitis C 3%, and hepatitis B 30%. So how to manage after exposure? This is published in 2001 Mortality Morbidity Weekly Round. And for hepatitis B, if the healthcare worker is vaccinated, he is safe, whether the source hepatitis surface antigen positive or negative. But if he is unvaccinated, you need to give him immunoglobulin, and this could be within 24 hours. If you give it more than 7 days, the benefit it's questionable, and you need to initiate hepatitis B vaccine. If the source is negative, you just give the hemophilia vaccine. But if he is unknown or not available, the status of the donor, you need to go like hepatitis surface antigen positive. If the employee is non-responder, like already mentioned, after 2 doses or 2 series of hepatitis B vaccine, you need to give him hepatitis B immunoglobulin, either once and you initiate the vaccine, or you give him 2 times hepatitis B immunoglobulin, as well as if the source is unknown. But if the source is negative, no treatment to be given. If he was given vaccine, but you don't know about his antibodies, whether he is immune or not, you need to check his antibodies. And if he is immune and the titer more than 10, he is safe. But if it is less, you need to give him immunoglobulin and the booster dose. How about hepatitis C? The problem with hepatitis C is that there is no effective prophylaxis. Immunoglobulin and antiviral are not recommended. And you need to determine the source. Establish baseline testing for anti-hepatitis C, viral load for hepatitis C, and baseline ALT. And then you need to follow up after 4 to 6 weeks by viral load for hepatitis C. And follow up after 4 to 6 months, anti-hepatitis C, hepatitis C virus RNA, and ALT. And if he's converted, you need to consult the gastroenterologist about that. Maybe he will give him treatment. How about HIV? Exposure risk, percutaneous 0.3%, mucomembranous 0.1%, and non-intact skin less than 0.1%. If healthcare employee will be converted, he will go into this. Either he will get a primary HIV infection, and this could happen in 81%, and this happened after 25 days of exposure. Keep it in mind. And if he will not pass into the primary HIV infection, he might convert and after 46 days. And seroconversion by 6 months, it could be happen in 95%, and 3%, they are converted after 6 to 12 months. And those patients, they get from the source also, he is hepatitis C positive. So when to start HIV BIP? No data to suggest when post-exposure prophylaxis must be started. Animal evidence suggests less than 4 hours, not effective when more than 24 hours. CDC recommended initiation within 1 to 2 hours, International AIDS Society as soon as possible, and unknown whether prophylaxis is no longer effective, not usually advised if more than 72 hours, and no limit for the highest risk exposure. Keep in our mind also that drug resistance to all available antiretroviral agents have been reported. And the cross-resistance within drug classes is frequent. So you have to determine the source. Here, the exposure type. Less severe, that means solid needle or superficial injury. More severe, that means large bore hollow needles or deep puncture and visible blood. For class 1 HIV, it means asymptomatic or viral load less than 1,500. And for class 2, it means that he is AIDS already or he have very high viral load. Also, for mucocutaneous, small volume, this is drops of blood, large volume, large quantity, and class 1, as I have already mentioned. In general, what to give? There are 2 we are using to make it simple for everybody. Either you will go with Combivir, which is a combination of AZT and lamivudine, AZT 300 mg BID, Combivir 150 mg BID, in combination 1 tablet BID. Or you will go with Truvada, which is a combination of tenofovir and imitricitabine in a dose I already mentioned. And how about the protease inhibitor? You will go either with Kaletra, which is a combination of lopinavir and ritonavir, and 3 capsules BID or 2 tablet BID, or you will go with azatanavir plus minus ritonavir. Keep in mind that you have to individualize your healthcare workers. from where the source. Because if the source have already resistance to the already I mentioned these groups, you will never use them. You will use the drugs that patient already use and he respond to. And you need to follow up. Counseling, periodical HIV testing for 6 months, that is 6 weeks, 12 weeks, and 6 months, and extend follow-up for 1 year if the donor combined with hepatitis C. Healthcare personnel should be monitored for drug toxicity by testing, and you need to do baseline CBC, liver function test, and renal function test. Routine use of HIV RNA not recommended unless you think that healthcare worker is converted in a primary HIV. You need at that time to order because HIV test it will be negative because he's in window period. You need to consult about avoid pregnancy, avoid blood donation, and he should practice safe sex. This is just quoted from HIV BIB registry, and most in general that those people who you will give in prophylaxis, they will stop it. And I experienced this one several times. They will stop it, and there is a lot of study regarding why those healthcare workers, they need to stop. Though we have many HIV patients, they have already for 7-8 days in antiretroviral. They said that they are continue with it, but this is maybe psychological because they will give them for 4 weeks and they are psychological. 43% they will.
2 minutes left.
Okay. So why reason they stop it? Either due to symptoms and side effect, or lab test result, or the source came to be negative. So what is the message can we take? We need to concern about needle stick injury and for the fluid exposure. We need to report the injuries, which is very important. Successful management depends on an organized and consistent approach to counseling and treatment. Provide immediate care to the exposure site. Determine risk associated with exposure. Give prophylaxis, posing risk of infection transmission. Provide counseling and perform follow-up. And this is the idea that we can get. Prevention is much better than cure. You have to follow standard precaution, use of barrier measures, improve non-compliance, not recap needle, failure to wash hands, failure to dispose sharp properly, and vaccination is very important. We are all responsible for the infection prevention and control. This is that we need to be together in order to prevent anything that happened to us. We need to be up with our work and together. Thank you very much.